Hello, everyone, and thank you for joining us for today's HOSP webinar. Please note this event is being recorded and will be available to all attendees soon after today's presentation. Any questions you have during the presentation portion of the event, you are welcome to do that via the chat or Q&A options at the bottom of your screen, and they will be answered when the presentation concludes. And today's speaker is Dr. Andras, and he's a Hematology Oncology Clinical Pharmacy Specialist at Cleveland Clinic, Akron General. And I will hand it over to him. Thank you very much.
I appreciate it. So today we are going to be discussing Brukinsa or zanubrutinib, specifically for the treatment of adult patients with CLL or SLL. Multiple indications with Brukinsa. Again, the focus today is going to be CLL, and we'll get into the discussion now. So I am presenting on behalf of BeiGene. I've been selected by them and compensated as such. Let's look at the story of Brukinsa and really, what's been happening over the last few years. Powerful efficacy, consistent safety demonstrated across 4 different indications. Again, today's discussion will centralize around CLL, but multiple indications out there, and it'd be great to take a look at some of the different powerful areas where Brukinsa has really been making a splash. High potency and affinity for BTK, and so we know BTK not a new target, but certainly important in many of our disease states. And so looking at the inhibition of BTK and the potency, we'll talk a little bit about that and where Brukinsa maybe stands apart there. Consistent benefit across patient subgroups and risk factors. So again, multiple patients, as we know, different diseases have different risk factors that play a role in terms of prognosis, and having a drug that works across the board is fantastic, and we'll get into those details. Unmatched dosing flexibility and no caution to avoid use in patients with severe hepatic impairment. And so again, when we have patients and we're selecting therapy, it can be quite a challenge when there's certain things that we can't easily fix, including someone's liver function. And so having a medication that can be used in such a patient with severe hepatic impairment is really a great option for us. And then BeiGene just showing unwavering commitment to support patients prescribed Brukinsa. And again, we'll assess that as well. So as we do during discussions like this, we will take a look at some of the warnings and precautions as well. When we think of BTK inhibitors, there's a couple of things that really ring true in my mind and things that come to the forefront. One being hemorrhaging or bleeding, as well as arrhythmias, and we'll go into both of those high-level pieces that BTK inhibitors really bring to the forefront. So in terms of hemorrhaging, fatal and serious events have occurred in patients with Brukinsa, grade 3 or higher, including intracranial, GI, hematuria, pneumothorax in about 3.6% of patients on Brukinsa. Fatalities occurring in about 0.3% of patients. Bleeding of any grade, excluding purpura and petechiae, about 30% of patients. Patients have had bleeding occur with and without concomitant antiplatelet or anticoagulation therapy. This is the first time that I'm discussing this point, so just for reference, and we'll hit this again, but Brukinsa can be used with both antiplatelet as well as anticoagulation therapy. For sign symptoms of bleeding, something that patients, if they were on antiplatelet or anticoagulation therapy, would already be apprised of. But one of the big points and one of the questions I do get on the back end, and so I'll bring this up on the front end, is really for surgery. What do we do with a drug if we know it causes bleeding and potential hemorrhaging? Or what do we do with those patients around the time of surgery? And straight from BeiGene here, the recommendation is to consider withholding Brukinsa for 3 to 7 days pre and post surgery, depending on the type of surgery and risk of bleeding. I know myself as a clinical pharmacist, I often get involved in these discussions, and I'm kind of a liaison between the hemonc and the surgery teams. And so again, kind of a simple recommendation. So have that discussion with your surgery group in terms of the potential for bleeding, and you can make the decision together. Infections. So Brukinsa certainly is myelosuppressive. Fatal and serious infections, including bacterial, fungal, and viral infections, as well as opportunistic infections, have occurred in patients with Brukinsa. Grade 3 or higher infections occurring about 24% of patients, most commonly pneumonia, and you'll see that on the more distilled slides as we go through them. Fatal infections occurring in about 2.9% of patients. Infections due to Hep B reactivation have also occurred as well. Continuing the discussion on infections, prophylaxis with HSV, PJP, pneumonia, and other infections according to standard of care at your facilities would be best. Monitor and evaluate those patients for fevers and other signs of symptoms of infection as appropriate. For myself at my center, one of the things when I talk to patients about new therapies, chemotherapy, oral or IV, I always bring them back to the infection risk and fevers, and so they understand what those things look like. As we know, things like febrile neutropenia obviously have, unfortunate mortality risks. We want to make sure patients don't get there for something that we can anticipate or potentially is preventable. The cytopenias, grade 3 and 4, including neutropenia, thrombocytopenia, anemia, have all been seen at the percentages listed there on the slide. So certainly CBCs in these patients, and then interrupting treatment, reducing the dose, or discontinuing treatment as needed. You can use growth factor or transfusions as needed to keep patients on therapy when it's beneficial. Secondary primary malignancies, including non-skin carcinomas, have occurred in about 13% of patients treated with Brukinsa. The most frequent second primary malignancy was non-melanoma skin cancer. In about 7% of patients, other second primary malignancies, including malignant solid tumors at 5%, melanoma at 1.2%, and hematologic malignancies at about 0.5% have also occurred. Also advise patients to use sun protection and monitor patients for development of second primary malignancies. Thankfully, I get to tell patients about that again. I live in Ohio, from Ohio, and finally we're seeing the sun after a few months of not seeing it. So nice to be able to at least tell patients about that as well, but certainly an important point for patients. As I discussed in the beginning, cardiac arrhythmias is another side effect that really comes to mind when I think of BTK inhibitors. And it kind of because our first generation BTK inhibitor kind of brought this to light, but still something that we continue to look at as with second gen BTK inhibitors. So serious cardiac arrhythmias have occurred in patients with Brukinsa, both atrial fibrillation and flutter reported in about 3.7% of 1,550 patients treated with Brukinsa monotherapy, including grade 3 and 4 or higher cases at 1.7%. So this, 1,550 patients, these are, again, remember in the beginning when I brought up, Brukinsa and all the different indications. And so one thing that's nice in some of these, probably not very rare, but some rare diseases, and maybe not high numbers that we may see in other, non-onc or non-heme indications, we have quite a few number of patients. And so really good confidence in terms of the safety profile. We have a good idea of what Brukinsa does in the patient population with these larger numbers. Patients with cardiac risk factors, including hypertension, acute infections, certainly at an increased risk. Grade 3 or higher ventricular tachyarrhythmias reported in just 0.2% of patients. So just monitor those patients for these arrhythmias. Again, sometimes I hear higher than what I see quoted literature for these arrhythmias, but as you can see here, 3.7% of patients, and we'll take a look at some of the comparative, perhaps with some other BTK inhibitor in this space. Embryo-fetal toxicity, for completeness sake, Brukinsa can cause fetal harm when administered to a pregnant woman. Administration of zanubrutinib to pregnant raps during the period of organogenesis caused embryo-fetal toxicity, including malformations that were 5 times higher than those reported in patients at the recommended dose of 160 milligrams twice daily. So it's best to advise women to avoid becoming pregnant while taking Brukinsa and for 1 week after the last dose, and advise men to avoid fathering a child during treatment and as well as 1 week after the last dose. If patients were to become pregnant during treatment, the patient should be apprised of the potential hazard to the fetus. Unlikely given the age of many of the diagnoses with the indications of Brukinsa, but still a consideration. As we look at the adverse reactions, the list here, I'm not going to reread this list. We'll take a closer look, I think, in the table format that's to come, and we can see where patients kind of ended up. But as you can see here, certainly monitoring patients with CBC, CMPs, and those bleeding risks is important. In terms of drug interactions, CYP3A inhibitors, when Brukinsa is co-administered with a strong CYP3A inhibitor, it's best to reduce the dose of Brukinsa to 80 milligrams once daily. For a co-administration with a moderate CYP3A inhibitor, best to reduce the Brukinsa dose to 80 milligrams twice daily. For our inducers, strong or moderate, it's best to avoid it when we can. If we need to use a moderate inducer, dose adjustments may be recommended. And so we'll go over that later in the presentation. For special populations, again, as I alluded to with hepatic impairment, it is tough to use BTK inhibitors in this space, but there's a recommendation here to use Brukinsa for patients with severe hepatic impairment to 80 milligrams twice daily as an option. So again, really great to have an option in those patients. Okay, let's take a look at BTK and BTK inhibitors. As we know, again, not brand new to target for CLL, but still interesting to rediscuss it, and so we can kind of start the story. So signaling through BTK is a key driver of CLL and SLL. The B cell receptor is a transmembrane receptor that controls B cell development and regulation, and BCR signaling acts through downstream signaling pathways activated by kinases, including BTK. BCR signaling through BTK does promote survival of normal and malignant B cells, and that's why it's such a target in a lot of these diseases that we're discussing, including CLL today. And now going forward, let's take a look at some of the PK/PD differences among BTK inhibitors. And so before I go through many of the slides that I'm about to present, I just want to reiterate that the content here is non-clinical data. Clinical relevance of the data has not been determined, and the data is not meant to imply comparative efficacy or safety. And so the way I look at the data I'm about to present, as I'm going to discuss it, is you have different BTK inhibitors, some in very similar spaces with similar indications. And so you have to make a distinction, a decision, as you're going through selecting these from these oral therapies. And these are just things that may also, you may want to take into consideration as you're making that consideration. And so first, what's Brukinsa all about? It was designed to meet the challenges of BTK inhibition. Again, as a second generation BTK inhibitor, the goal was high potency and affinity for BTK, 100% inhibition with twice daily dosing, up to 100% inhibition with once daily dosing. And again, inhibition of mononuclear cells was 100% in both BID and daily dosing. And so we'll go into that further. Inhibition in lymph nodes was 100% with twice daily dosing and 94% with daily dosing. Sustained 24-hour inhibitions, concentration levels continuously maintained above the IC50 for 24 hours. And we'll talk about why the IC50 is, potentially quite important. A low off-target binding. When we look at BTK inhibitors and really like tyrosine kinase inhibitors, and I think of my mind even like second-generation antipsychotics that have many off-targets. So we don't like off-targets. Generally speaking, that's where we get a lot of our side effects from when they're off-target and not centralized to BTK. And so high affinity for BTK with low off-target binding would hopefully lead to reduced side effect profiles. And we'll talk about some of those one of the comparative trials that we have. But again, some of the high affinity for BTK, low off-target binding, including TEC, HER4, and JAK3. Okay, so inhibition, BTK inhibition, median steady state. So as we see here, I kind of alluded to Brukinsa's inhibition here, 100% in the mononuclear cells and 94% in lymph nodes with once daily dosing. Twice daily dosing was 100% in both. We look at ibrutinib, we know it's at least 90%, and acalabrutinib, we know it's at least 95% in the mononuclear cells. So again, just some consideration to be had as we're looking through this consideration. Looking at BTK inhibition over time, so these three agents that we have, again, ibrutinib being our first generation, and Brukinsa and acalabrutinib being more of our second generation, we know BTK is continually synthesized, and so having inhibited, would be important for us. And so looking at Brukinsa, regardless of whether it's dosed once or twice daily, this is a question again that I commonly get on the back end. There is no difference in either strategy for dosing. As you can see here, either with once or twice daily dosing, we spend 0 hours below the IC50. With ibrutinib, we know we're about 17 hours below, and acalabrutinib, we know we're about 19 hours below. So again, we don't know exactly what clinical manifestation this translates to, but just for your consideration as you're selecting between different BTK inhibitors. As we all look and work in oncology every day, NCCN is something we commonly reference. So here we have the recommendation, zanubrutinib is in the NCCN guidelines for CLL. So without deletion 17p, it is a first line category 1 recommendation. With second line, it's a category 2A recommendation. With deletion 17p, for first and second line, it's a category 2A recommendation. And as we're aware, these are, obviously pulled out in CLL, deletion 17p with or without. And it was, as we're, if you treat CLL commonly, you're probably very accustomed to deletion 17p, knowing that these patients generally have a poor prognosis with treatment and can be quite a challenge to treat. And so that's why we pull those out. And as you'll see what we did in the trial as well, differentiate between these two. So we'll take a look at the Alpine and Sequoia trials. So first and second line superiority in CLL. We have the Sequoia trial, study 304, and then the Alpine study 305, and we'll discuss these each separately. So first, we'll look at the Sequoia trial. This is superiority in first-line CLL. This is Brukinsa versus BR, better known as bendamustine and rituximab. So this study was designed to evaluate superiority of Brukinsa versus BR in the first-line CLL. It was a global phase 3 randomized open-label multi-center trial conducted in patients with previously untreated CLL, SLL, initiated in 2017. Of note, the year is important, I think, when you're looking at standard of care for patients with CLL and bendamustine rituximab. Certainly is an option even today, but just a consideration, when you're looking at the different, the comparative arm, it was done in 2017. So we have two cohorts, one without deletion 17p and one with. The cohort 2 was just Brukinsa by itself at 160 milligrams twice daily until disease progression or unacceptable toxicity. Our cohort 1, though, was Brukinsa 160 milligrams twice daily, versus bendamustine rituximab at 6 cycles maximum. Primary study endpoint for cohort 1 is progression-free survival with select secondary endpoints of overall response rate as well as PFS. In cohort 2, response is determined using IRC, using modified IWCLL criteria and Lugano criteria for SLL. Just again, I kind of alluded to this, but the cohort 2 rationale, because patients with CLL and SLL whose tumors exhibit deletion 17p have an unfavorable prognosis, respond poorly to standard chemoimmune therapy. Those with deletion 17p mutations were assigned to receive Brukinsa in a separate single-arm exploratory analysis, and I hope that makes sense. Looking at our baseline characteristics, or really what I refer to as table 1 data, you can see a pretty even spread here across the two groups with Brukinsa and BR in our cohort 1. There was one deletion 17p that snuck in there, but otherwise you can see quite equal across the board. Looking at comorbidities of interest, and this is really where I think a lot of clinicians want to see is, as we discussed, and I started out with some of the safety concerns with BTK inhibitors, including cardiac disorders, AFib flutter, as well as even hypertension. These are things that we'd want to see. If I have a patient with atrial fibrillation or flutter at baseline, can they go on such a therapy? And the answer is yes, and they were included in the trial. So you have some of that available to you. So as you can see, history of cardiac disorders, 27% in Brukinsa and 29% in the BR arm. So again, both included, and then certainly even in our deletion 17p, there was representation there as well. So taking a look at some of the outcomes here. So superior progression-free survival versus BR in patients without deletion 17p, and consistent PFS in patients with deletion 17p. So really nice to see this. 86% versus 70% in the Brukinsa versus BR, a cohort 1 arm, with a 58% relative risk reduction with the Brukinsa patients. When we look at cohort 2, PFS at 2 years, we see 89%. And of note, cohort 2 is really the largest prospective study of first-line patients with deletion 17p. So really nice to have that. One of the things I think in oncology in general is we have limitations, as some of our diseases are a little bit rare or are very hard to treat ones. We generally don't see large numbers a lot of times in these difficult to treat patients. And so having here again, this cohort 2 being the largest prospective study of first-line patients with deletion 17p is quite nice to see. Again, even albeit limited by itself, it is exploratory in nature. Still having this, I think, is great to have in our back pocket. Just taking a look at the different subgroups. And so again, in patients without deletion 17p, PFS generally favored Brukinsa regardless of mutation or risk status. So you can see the forest plot here depicted on the screen across the board. For the most part, all favoring Brukinsa. So you can see TP53, quite a large confidence interval there. It's maybe not quite as meaningful, but across the board with the other items there in risk factor groups, really favoring Brukinsa. Again, as I'm selecting therapy for my patients, one of the things that I like to look at is where does my patient fit or not fit in a trial, and should I be using the therapy on this particular patient? And so having this again kind of gives you some confidence with Brukinsa compared with BR in the study. Looking at the overall response rate in patients with and without deletion 17p. So cohort 1, 93% overall response rate. In our BR arm, 85%. But looking at our cohort 2 with just deletion 17p, 88%. So as you can see, the ORR was really consistent for patients regardless of deletion 17p status, which is nice to know, again, given the fact of these deletion 17p patients generally having a poor prognosis. So having consistency is very good. Looking at our adverse reactions, and as we look at these slides, and I'm looking at our grade 3 or higher adverse effects, and I really draw my eyes there. Those are the adverse effects for the most part that take patients off therapy or get patients admitted, and so I kind of draw there. And as you can see, some similarities between the two groups of Brukinsa and BR. I think when I'm trying to describe, tolerability with these agents, is one of the things I always say is I always think of two different things with tolerability, and that's dose reductions as well as discontinuation rates. And those two things will usually tell me how tolerable a drug is. If a patient can stay on therapy with minimal dose reductions, and the drug's probably quite tolerable. And if they stay on the drug and don't discontinue it, also would tell me it's quite tolerable. And so we compare Brukinsa with BR. We see dose reductions in Brukinsa arm at 14% and BR at twice that, over twice that at 36%. We look at discontinuation rates, we see 8% in Brukinsa and 14% with bendamustine rituximab combination. Taking a look at cohort 2, dose reductions at 10% and discontinuation rate 5%. So some similarities there to cohort 1. And again, if you look on the right side of the screen here, the pooled safety information with Brukinsa, this is the exposed 1,550 patients. You can see again consistency, which is exactly what we want to see. Really nothing new or alarming as we go through and see the drug trialed in different disease states. Side effect profile is pretty well established at this time. Taking a look at some other lab abnormalities here. So kind of our CBC CMP information, if I can call it that. Again, just good to know and watch patients. You can see the neutrophil count decrease with Brukinsa, grade 3 or higher, 15% versus 53% with our BR regimen. Otherwise, seeing some other pieces and parts there listed. Just important to get CBC CMPs on our patients. As again, the drug is myelosuppressive, and just want to make sure patients have good organ function as they're progressing through therapy. Some of our adverse effects of interest here, obviously, again, the cardiac risk factors is, that's what a lot of people think about when we discuss BTK inhibitors. You can see in the Sequoia trial, AFib flutter, a grade 3 or higher, 0.4%. With BR, it was actually 1%, which, again, take it for what it's worth. This is what the trial kind of showed us. Major bleeding 4% in the grade 3 or higher, and 2% within BR. So some comparative, again, we know BTK inhibitors have a higher propensity for these things, but as you're looking through the differences, just make those good considerations for your patients as you're selecting therapy when looking, again, I don't want to say the bad rap that BTK inhibitors get, but sometimes the hyperinflated side effect profile that I see, sometimes based on our first generation drugs. Okay. So speaking of first generation drugs of BTK inhibitors, ibrutinib, so this was a head-to-head superiority in second line CLL, our Alpine study 305, Brukinsa versus ibrutinib. This study was designed to evaluate superiority of Brukinsa versus ibrutinib in second line CLL. So this is a phase 3 randomized open label multi-center trial conducted globally in patients with relapsed refractory CLL who received at least one prior systemic therapy. So we had 652 patients randomized to receive Brukinsa at 160 milligrams twice daily until disease progression, or ibrutinib 420 milligrams daily until disease progression or an intolerable toxicity. Primary endpoint was overall response rate with select secondary endpoints of PFS and AFib flutter. Again, responses determined using both investigator and IRC assessment using modified IWCLL criteria as well as Lugano criteria for SLL. Okay, so looking at our table 1 data, again here, pretty even spread between the patients. You can see a lot of the previous treatments. That's usually what I want to see. Again, we're looking at second line patients, so I want to see, did they receive the typical usual treatments I would expect? The other thing I would note too is you can see median prior lines of therapy for those of you out there with some maybe really refractory CLL patients. As you can see in the Brukinsa arm, anywhere from 1 to 6 previous treatments. It's just something to draw your eyes to, so this is the indication certainly in the second line. It's what was being evaluated. But you can see patients that were on, 3rd, 4th, 5th, and even 6th line of therapy. Good spread for a range of age. As you can see, over 65 years of age, 61% of patients. So as you know, patients are getting, more advanced in age, and having them included in trials is important as well. Looking at the comorbidities, again, these are the ones of interest. History of cardiac disorders, so AFib, flutter, as well as hypertension included in our patients as well. So again, both baselines, BTK inhibitors, we had these patients with these baseline, comorbidities included. And I think it's, again, just important to note as we see patients with arrhythmias, with hypertension, they can certainly still go on therapy, even these BTK inhibitors that, again, have those elevated risks. And we'll see exactly what happened in the trial. So Brukinsa, looking at PFS, is the only BTK inhibitor to achieve superior PFS versus ibrutinib. So 78% in the Brukinsa arm, 66% in the ibrutinib arm, yielding a 35% relative risk reduction with Brukinsa. Brukinsa also delivered longer PFS versus ibrutinib in patients with deletion 17p. Again, those challenging patients. Median PFS has not been yet been reached with Brukinsa versus 34 months with the ibrutinib arm. So great, again, to have this comparative data. We don't see a lot of comparative studies in similar classes of drugs. So having this with the BTK inhibitors, I think is real powerful for us as clinicians. Looking at PFS versus ibrutinib, now taking a look at mutation or risk status, as you can see, generally across the board, consistent PFS versus ibrutinib, regardless of the different mutation status and risk factors listed here. And so as you can see across the board, again, another forest plot really favoring Brukinsa across the board, regardless of those different risk factors and mutations. So looking at some more data here, the overall response rate. So Brukinsa being the only BTK inhibitor to achieve superior overall response rate versus ibrutinib. So here we have 80% versus 73% ORR. With Brukinsa, 92% of patients did sustain a response versus 86% with ibrutinib at 1 year. So important to have that data too. So as patients go on therapy, we want to make sure that they're doing well, not just initially, but over time as well. And so again, having this overall response rate data here with the two BTK inhibitors, again, a very good, powerful information for us to have as clinicians when we're, selecting therapies. As I discussed in the previous trial, looking at tolerability for our patients. So taking a look again at those grade 3 or higher adverse effects, as you can see, down the line, reasonably comparative across the board versus in this trial with Brukinsa and ibrutinib. The pooled safety information, again, on the right side of your screen to really tell the story of Brukinsa on a larger exposed population. But a couple of things to note. So rates of hypertension were comparable between Brukinsa and ibrutinib. Medical history of hypertension was reported in more than half of these patient events for both Brukinsa and ibrutinib. And now, again, what I refer to as the tolerability data. So dose reductions and discontinuation rates. So dose reductions in Brukinsa, 12% versus 17%. Discontinuation rates, Brukinsa 15% versus ibrutinib at 22%. So again, numerically lower in both in the Brukinsa arm. Take a look at some select lab abnormalities that worsened from baseline. Again, kind of our CBC CMP data as you're looking at both of these. Again, pretty comparable across the board. So just a reminder, again, make sure we're assessing patients for some of these, again, the myelosuppressive effects as well as our organ function too. Taking a look at cardiac disorders, AFib, a flutter versus ibrutinib. So as you can see here, looking at cardiac disorders over time, 21% versus 30% with ibrutinib over time, and we'll get to some further data regarding the comparing these two agents when they flip from ibrutinib to Brukinsa. But as you can see, over time, a separation there with Brukinsa at 21% and ibrutinib at 30%. When you look at the pre-specified analysis, that's shown for you as well. Again, important as we know when we think of BTK inhibitors, cardiac disorders is one of the first things that really comes to mind. Of note, no fatal cardiac events occurred with Brukinsa versus 6 in the ibrutinib arm. Okay, so looking at some select adverse reactions in this in the Alpine study, some of these that again I think we attribute to BTK inhibitors quite readily. AFib and flutter again here. You can see reasonably comparative, grade 3 or higher, 3% in Brukinsa versus 4 in the ibrutinib arm. When you look at our pooled safety information, even lower, grade 3 or higher at 2%. But still something, again, we still want to continue to monitor and watch these patients, closely as these things can be very treatment limiting, if I can say it that way. Otherwise, kind of the things we would expect from BTK inhibitor study. So now we'll step into some patient cases. So our first patient is a drug-naive patient. So Jonathan is a previously untreated CLL patient. He's a 65-year-old Caucasian male presenting with fatigue, unintentional weight loss, ECOG performance status of 1, imaging PET-CT lymphadenopathy above and below diaphragm, his largest node listed there for you. Comorbidities including hyperlipidemia as well as CKD, and concomitant medications, atorvastatin as well as omeprazole. As we know, many patients are on our PPIs and can be interacting with other drugs, and so make sure we're watching out for that as well. Looking at his workup, lab values at current presentation, so elevated white count certainly, hemoglobin low, platelets listed, LDH as well, karyotype not complex, FISH, so deletion 17p, IGHV unmutated, he does have TP53, and some splenomegaly listed there. So looking at Jonathan as a patient, would we consider him for a BTK inhibitor? I think he'd be a great candidate. Again, given the indications with an NCCN, it would be a great, Brukinsa would be a great option for him. Looking at deletion 17p, these patients were, we have a study on them included, albeit single arm. I still think it's important for these patients and not have to go on an IV therapy and still have great response rates. Looking at Emily, she's a relapsed CLL patient, so a 71-year-old Caucasian female, asymptomatic identified about 5 years previously, initially monitored after 2 years, developing anemia, night sweats, splenomegaly, some of those B symptoms, treated with venetoclax and obinutuzumab. So again, venetoclax, really watching out for a TLS there, and then obinutuzumab, another anti-CD20 agent, I'm sure we're all familiar with. Relapsed 1 year later, current presentation, she has ECOG performance status of 1, palpable splenomegaly, PET CT showing lymphadenopathy above and below diaphragm, largest node listed there. Some comorbidities of interest: CAD, high cardiovascular risk due to history of NSTEMI, status post 2 stents, cluster headaches as well. Some concomitant medications of interest: simvastatin, amlodipine, clopidogrel, and aspirin. So dual antiplatelet therapy, again, something to consider in our patients. Looking at her workup, otherwise reasonably normal. So deletion 11q with no deletion 17p, unmutated TP53. So as I'm evaluating, and you're evaluating a patient like this in the relapse setting, in my mind, when I look at a patient like this, I see she's already been on an oral chemotherapy, so probably a good patient in terms of compliance. She's been on obinutuzumab, so being an anti-CD20 agent, it would be nice to try something different. Obviously, dual antiplatelet therapy, I know Brukinsa has data there where we can use it with that, so concomitantly would not be an issue despite the bleeding risk or hemorrhaging risk with Brukinsa as I described it. So again, a great patient for BTK inhibitor, a great patient and candidate for Brukinsa. So now I'd like to go into Brukinsa and ibrutinib intolerant patients. So study 215, this was a phase 2 exploratory piece. And before we go in this, as well, I'll say again on a subsequent slide here, and we're looking at these patients that I'm about to describe, or this little exploratory phase 2 study. These are intolerant patients to Brukinsa. They have not failed a BTK inhibitor. They are intolerant to ibrutinib. And so very different than failed patients, as you know, if you're looking at a lot of the trials with Brukinsa. Previous BTK inhibitors patients who had been on previous BTK inhibitors are generally excluded from the trial. And so here, before we get into the trial, let's take a look at George. He's a 69-year-old retired Caucasian male, diagnosed 16 months previously with symptomatic CLL. He's treated with ibrutinib monotherapy and experienced a partial response by month 6, which is great for him. At 16 months, presented with fatigue, dizziness, and heart palpitations, so not so great. He's diagnosed with atrial fibrillation, ECOG performance status of 1, some comorbidities of note, type 2 diabetes, as well as hyperlipidemia. Some concomitant medications, metformin and BID. His daughter reports that George sometimes has trouble remembering to take his medications. So again, it's a challenge with many patients, compliance, especially those that require BID dosing, atorvastatin as well. Looking at his workup listed there for you, no deletion 17p is one of the things I would be looking at, and no splenomegaly. So he's had a good response. To a BTK inhibitor, ibrutinib, a first-generation drug, unfortunately experienced what some patients do, which is an arrhythmia, these cardiac concerns going forward with this patient. And so what do we do with a patient like this? And we'll return to George after discussing the intolerance study. So Brukinsa was studied in patients who discontinued ibrutinib due to adverse events. So this was a phase 2 single-arm, open-label exploratory study of Brukinsa in patients who experienced adverse effects on ibrutinib, including those with CLL or SLL. So 62 patients who were intolerant to ibrutinib were put on Brukinsa, 160 milligrams twice daily or 320 milligrams daily until disease progression or unacceptable toxicity, with a primary endpoint of recurrence and change in severity of ibrutinib intolerant events. This is investigator assessed, as well as some secondary endpoints as well. Looking at inclusion and exclusion criteria, I think this is important to note. So inclusion criteria, they had to be intolerant to ibrutinib despite optimal supportive care. So these are patients where we tried to keep them on. They were tried to keep on ibrutinib. It wasn't just one side effect and we pulled the plug on them. They did get optimal supportive care. As well as resolution of ibrutinib toxicities to grade 1 or less, or baseline before the initiation of Brukinsa. So the goal was that they would have some resolution of some of the side effects prior to starting Brukinsa. Exclusion criteria, important, very important as I started with this, disease progression during prior ibrutinib treatment. So again, that was an important note there. All data here, exploratory, descriptive in nature. So just of note, we're not going to be looking at p-values here. So here's some of the important information. So 70% of patients who switched to Brukinsa after ibrutinib intolerance experience improved tolerability. 7 out of the 9 patients with a history of AFib or flutter did not have a recurrence with Brukinsa. AFib occurred in 3 patients, all were grade 2 events, and 2 actually had prior AFib. Less than 10% of patients treated with Brukinsa discontinued due to adverse effects. And then 94% of patients treated with Brukinsa maintained or improved the response over baseline. This is kind of a secondary endpoint. I think this is all important information, as you know, some patients would have been started on ibrutinib, and whether you're looking at the data and maybe you're impressed by what you've seen here today with Brukinsa, just a consideration that, you know, switching patients is, you know, this is a question that my oncologist may be throwing my way. You know, is there data to support this? And again, this is albeit a limited piece. We do have a good number of patients here showing some of the data. And I think this is important to consider as you have a patient who maybe has a good response to BTK inhibitor, but maybe just couldn't tolerate ibrutinib. And so just showing you what Brukinsa may be able to do for your patient in that setting. So coming back to George here, looking at him as a patient, a great response to BTK. As we look at CLL, and we look at, you know, for those of you that have been treating CLL for a long time, you're not seeing a lot of your patients die from CLL. It's in fact, a lot of times it's something else at this point. You know, I almost get to the point of saying you die with CLL, not from it. And so these patients need sustainable therapy. But one thing I don't like to do is switch therapies and switch away from them when it's intolerance. I like to try and make them as tolerable as I can, whether that's dose reductions or optimal supportive care, which, as we looked at in the switch study there, optimal supportive care was offered, yet still patients couldn't stay on the ibrutinib. And so with this patient, I would like to not call BTK inhibitors a fail at this point, and perhaps switch him to Brukinsa based on the information I just presented. I think Brukinsa would be a good option. He could take it once daily. So noting with his metformin, BID dosing isn't ideal for him. Switching to a daily a drug that he can take just once a day perhaps would help his compliance there. You know, here we know he did well with ibrutinib, so a daily medication as well. But just some things of note to consider. You know, switching therapeutic class is not something I would want to consider. Given his partial response by month 6 already, I would want to continue with this and kind of, you know, squeeze the efficacy out of the BTK inhibitors as much as I could. And I think Brukinsa offers, from a safety and efficacy perspective, a great alternative in this setting for him. Okay, so I've discussed Brukinsa dosing, alluded to it a few times, and now let's get in kind of the nitty gritty. So Brukinsa is the only BTK inhibitor with dosing options, once or twice daily. What's really nice is Brukinsa comes in 80 milligram capsules once daily. So once daily dosing, considered for patients with compliance concerns or those who prefer taking their medications once daily. Twice daily, considered for patients who take other twice daily medications who maintain a consistent dosing schedule. I will tell you from clinical experience, a lot of my older patients actually tend to take the twice daily dosing, and some of my younger ones once daily. As long as they remember to take it is the most important thing. As you saw, like the IC50 information that I presented earlier on PK/PD considerations, again, very similar. So I don't think there's concern with efficacy. With severe hepatic impairment, again, Brukinsa is the only BTK inhibitor with recommendations here. So adjust the dose to 80 milligrams twice daily. No dose adjustment needed for mild to moderate hepatic impairment. We'll talk about dose modifications on a subsequent slide here, but it is very simplistic, something I really like with Brukinsa. Again, those 80 milligram capsules, I think it comes in really clutch. So looking at dose modifications, these are for grade 3 or higher adverse reactions. Adverse reactions that require dose modification. So grade 3 or higher non-hematologic toxicities, grade 3 febrile neutropenia, grade 3 thrombocytopenia with significant bleeding, a grade 4 neutropenia lasting more than 10 consecutive days, or grade 4 thrombocytopenia lasting more than 10 consecutive days. So here's our recommendations from BeiGene. Starting dose at 320 milligrams total daily dose. So it doesn't matter whether you're doing it 160 milligrams in the morning and evening, or all at once, 320 milligrams, again, 80 milligram capsules. At the first occurrence of one of the adverse reactions listed to the left, there's no dose change required. You just continue, resume treatment once toxicity has resolved to a less than grade 1 or baseline level. At the second occurrence, it's best to reduce the dose to 160 milligrams total dose. So 80 milligrams twice daily or 160 milligrams at once. At the third occurrence, it's best to reduce to 80 milligrams total dose, so just once, one capsule once daily. And a fourth occurrence, best discontinue in the interest of the patient. As I stated, no dose exchange required for dose modifications. And so when we look at different therapies and considerations for modifications, you know, for me, especially with chemotherapy, really any drug, but certainly chemotherapy of any type, when you have to make a modification, it always happens on those Friday afternoons or evenings when you're not going to be able to get a specialty pharmacy to get a prescription filled and out to the patient in time. And so now they're stuck over the weekend, maybe in limbo a little bit. With Brukinsa and 80 milligram capsules, all you're telling them to do is take 2 capsules, take 4 capsules, take 1 capsule. It's very simple, just manipulate that way. And one of the things I think of in a practical sense is, some of the patients we have are at more advanced stage and maybe not so good with knowing milligrams and understanding the differences. And so just telling them take, again, just number of capsules, I think that's usually simple enough. And sometimes I know I've done drug calendars for my patients where I've filled things out and, makes it very simplistic for them. Nothing worse. I know this is one of my worst fears when I have multiple strengths of a single medication that a patient's on, because when they come back to me, they have, pieces and parts of those medications, and they're trying to, show me what they've got left over. And I have no idea if they took the medication correctly, and neither do they. And based on what I have in front of me, they probably didn't, but I can't be certain. And so having this with Brukinsa, I think, keeps it quite simple for our patients. Okay, for those pharmacists on the line, drug interactions are a big part of what we do and we assess. So in our moderate CYP3A inhibitors, the dose adjustment there, 80 milligrams twice daily. Some of those inhibitors include erythromycin, fluconazole, verapamil. Our strong CYP3A inhibitors like erythromycin and fluconazole, 80 milligrams twice daily. For our moderate inducers, it's best to avoid use in these patients, concomitant use. But if these inducers cannot be avoided, you can use Brukinsa at a dose of 320 milligrams twice daily. Again, because these inducers will kind of, force the metabolism of Brukinsa. For our strong inducers, it's best to avoid use entirely with those agents, carbamazepine, phenytoin, rifampin included. So take-home message here: Brukinsa can be administered with strong, moderate CYP3A inhibitors at a reduced dose, and even CYP3A inducers if needed here as well at an increased dose. One of the biggest things I think about when looking at this slide and these interactions, and really like my personal message, is when you see agents, the interactions that are listed here, one of the things of note is a lot of these interactions are transient. As you can see, generally patients on erythromycin, fluconazole, anti-infectives, generally not going to be on these long-term always. And so if a patient is on this, I know myself within our EMR, we use Epic at Cleveland Clinic. I use little virtual sticky notes. I use them in person too, but I have a virtual sticky note on patients that just to remind me why a patient is on or has a dose modification to any agent. And so that way I know when they've stopped that offending agent to go back on the correct dose. And the point kind of alludes to on the right-hand side of the screen, after discontinuation of a CYP3A inhibitor or moderate CYP3A4 inducer or resume previous dose of Brukinsa. So just remembering to do that. I feel I often find patients who get admitted months later, maybe have fallen off my radar and the oncologist's radar, when I see that they've, they're still on a modified dose and they've stopped the offending agent. So just make sure, nothing worse than having a patient come in 3 or 4 months down the road. You're taking a look at where the disease activity is at, and you're not sure if they've been taking the medication or getting exposed to the correct amount of medication as they should have. It's just a good note to make sure we're watching out for those patients. Okay, so pricing and distribution, just some quick information. When we think of, the new kid on the block, or second generation therapy, we generally think of it's more expensive. But as you can see on the slide above, Brukinsa has the lowest wholesale acquisition cost on the market based on a 30-day supply. It's just something to consider. Here you have Brukinsa, acalabrutinib, and ibrutinib listed there for you. So again, Brukinsa being the cheapest one here. Just something to consider. I know there's other considerations with cost, but something I think to note. As you can see, it is the cheapest of the BTK inhibitors at a WAC consideration. Looking at distribution, so we have specialty pharmacy for commercial product and specialty distributors as well. So both listed there. So, Brukinsa is obviously accessible for your patients, and so accessibility shouldn't be an issue. I know getting patients on therapy, is usually the most concern. Once we've decided what the drug we're going with, we want to make sure they can get therapy, and that's quite important. And it kind of rolls into my next piece here, closing out with my BeiGene support for patients taking Brukinsa. It's a great program. And one of the things at the bottom, I'll start with actually, BeiGene does offer eligible healthcare professionals with samples or vouchers. So utilization of these, I think, are great for patients who need to get on therapy really ASAP. And for more information, reach out to your local reps. But my BeiGene offering simplifying access through financial assistance. So copay as little as $0 for some commercially insured patients, a 30-day bridge supply for those with insurance coverage delays, and free product for uninsured and underinsured patients. educating patients and caregivers about their treatment disease. So dedicated oncology nurse advocates available. I think that's great to have, a dedicated oncology nurse to help, and then connecting patients with services that deliver day-to-day living support for your patients as well. Okay, so kind of summarize our discussion this afternoon. So really with Brukinsa, efficacy demonstrated across lines of therapy in CLL and SLL. So without deletion 17p, superior PFS versus bendamustine rituximab, 86% versus 70%. Really nice to see that. With deletion 17p, so those patients with a poor prognosis, estimated PFS in the pre-specified analysis, 89% at 2 years. That's our first line Sequoia data there. Again, a very large cohort with that deletion 17p prospectively. Looking at superiority versus PFS versus ibrutinib here, this is our Alpine data, 78% versus 66%. Again, really important, I think, to see this data with in the second line setting for CLL2, having the comparative with ibrutinib. We don't usually see this. As all of you that are in oncology are very aware, we don't normally see that with drugs in the same class. But having this, I think, is really robust and gives some confidence in using Brukinsa. Looking at adverse effects, so consistent low rates of AFib and flutter and discontinuation. So that speaks to tolerability in my mind. So AFib and flutter, 3.3% versus 2.6% in BR. Discontinuation rates here, 8% versus 14% with BR, and 5% in the deletion 17p only patient population. Looking at our Alpine data, 5.3% versus 3.3% of AFib and flutter in those patients with discontinuation rates when we're comparing our BTK inhibitors, 15% versus 22%. So again, as a reminder here, zanubrutinib or Brukinsa, preferred treatment option for patients with CLL without deletion 17p, first line category 1, and then second line category 2. With deletion 17p, so those more challenging patients, first and second line, both category 2A recommendations. I've gone over much of the adverse effects and summarized those, and hopefully, again, you kind of gotten comfortable with that. With that being said, I'd be happy to take any questions if there are any. Feel free to put those forward or drop them in the chat.
Thank you very much, Doctor. That was a fantastic presentation. Truly appreciate it. I'm going to give the opportunity for some questions to pop in. It seems like you addressed some of them directly, almost anticipating questions that would be coming. So we'll hang on just a moment, see if we have anyone coming in. Thank you very much. I imagine you were addressing questions you've already received about.
Absolutely.
Already, yeah, because I had a seed question, but that was already addressed. So we'll see if anyone has any. Otherwise, we'll give it a minute and we'll see what happens. We did have a couple more people on at one point. See if I have anything from them. Clear signs of a good presentation. Answered all their questions. Well, if there are no questions, we can give everyone the 10 minutes back in their day, and this will be available after. So I will also say, I don't know how they will handle it, but if we get any questions coming in afterwards, after we've posted this recording, we'll send those your way as well, so you can address those.
Sounds great. I appreciate it.
Awesome. Thank you very much. And I hope everyone has a very good rest of your day. You'll be receiving an email with this recording, and we'll send that out to all the other registrants as well. And thank you for coming.
Thanks.
Thank you.